Now, has he let me sharing screen? No, bugger it. Oh, that don't help. Give me a minute, I'm going to email him. Okay. All right. Nice open-ended question for you. Does anybody have any questions from the videos, last week's Zoom session, the week before the videos, or anything else to do with manual therapy? You can ask me anything because
Hey, Jim, you can share your screen.
Okay, thanks, mate. I've got opinions on everything, so you can ask me what you like and you'll get an opinion, but preferably more about professional stuff.
But he is a dapper dresser, so clothing, apparel, and choices are fair game too.
Hey, Jim, I did have a question.
Yeah.
You talk quite a bit about pain coming from the dura, and that's something that's new to me. So I was curious, if just anecdotally, or if you know any research or literature that shows, how prevalent that is when you're actually dealing with somebody who has back pain. That's just something new to me that I've never quite heard of. So I was curious, how common that is.
Okay. I've got to think about this because it's well understood that the dura is nociceptive. So I've got to think about it. I mean, I can look for you, but it's such an understood thing. I really can't think of a study offhand that shows there is nociceptors in there. But essentially, if you've got a disc herniation and you're not getting neuropathic pain with it, which is very common, and you do a straight leg raise, the somatic pain you'll get from that straight leg raise is dural, because you can make it worse with neck flexion and so on. The SARGS test is going to reproduce the same thing as straight leg raise. So there's no doubt about it that this is dural. In fact, meningitis, which is entirely dural pain, can produce such a response in your muscles as to cause you, with a bacterial meningitis, to have only your occiput and the heels of your feet in contact with the bed, because everything is trying to relieve the stress on the dura. I don't think I'm answering your question, though, because it's actually sort of stunned me. Nobody's mentioned to you that the dura can cause pain, John?
It's honestly, no. I hadn't really even known about, I mean, I know what the dura is, but not in the way that we've discussed it till, watching some of the videos and listening to what you have to say. To be honest, though, I mean, that explanation there did answer another one of the questions I was going to ask, just asking about, the somatic response when you do, a straight leg raise. But I mean, if you're not quite sure on the, actual prevalence, that's okay. I think the second question I had was a little bit more important anyways, and you did address that, so I appreciate it.
Okay. When you do a straight leg raise, I can pretty much guarantee that most of your patients with a disc herniation or not with a disc herniation, when straight leg raise is positive, will give you non-neuropathic pain. To get lancinating pain down the leg with a straight leg raise is as unusual as seeing lancinating pain anyway. Now, if lancinating pain comes from damage, pathology to the nerve, not simple compression, so the nerve's been damaged, so that when you do a straight leg raise, for example, you stress that damaged point and the nerve seems to fire ectopically. So this isn't referred pain. This is direct from that damaged area in the nerve, zinging down the nerve. Whereas referred pain, somatic pain from a straight leg raise, is not local. That's all in your brain. That's in your cortex where you're feeling that. And it's almost an hallucination of pain. Referred pain is almost an hallucination. There's no local reason for you to have that pain. There's no pathology that's causing it. It's just referred and it's felt in the cortex. But lancinating pain is directly from the nerve. And it's non-nociceptive type pain. That's why it doesn't feel the same. And it's the same with coursalgia and so on. So nearly all of the pain, like if you have a disc herniation, it's going to compress the dura. If there's a radiculopathy present, it's also compressing the nerve. So the somatic pain dominates those symptoms as far as duration. The lancinating pain will dominate the symptoms in terms of severity. This is an intolerable pain. Fortunately, it just zings on and off, but it's completely intolerable. But it is short-lived, and it's only when the nerve is being stressed. Whereas the dural pain can last a longer time, much longer time. So the dura is definitely nociceptive, but I can't think of a single study. I'll see if I can find one for you, okay?
I appreciate it. Thank you. And, that explanation does help out clear up some other things, because it is hard to, differentiate between, like the referred pain versus lancinating pain. So that was very helpful. So I appreciate it. Thank you.
It's only difficult if you're trying to do it objectively. I don't like to differentiate them is all about the quality of the pain. If they're complaining of neuropathic pain, so it's an electric shock pain, and it is an electric shock. Okay, it's not a sharp pain, it's not a stabbing pain, it's an electric shock. And it zings down the limb or around the chest or wherever it's going. It's the same pain you get with shingles, for example. So that's neuropathic pain. Nothing else you can do will change that. Coursalgia is a little bit more difficult to distinguish because it's more variable than lancinating pain. Lancinating pain is a 12 on a 0 to 10 scale, if you like, always. Lancinating pain has degrees of severity, and it can be a really hot burning sensation, or it can be much milder burning. It can be an itchy pain, scratchy pain, and so on. So that's a little bit more difficult to interpret, but you don't come across that very often, except for peripheral neuropathies, particularly those caused by things like diabetes, vitamin K, where there's actually damage to the peripheral nerve. So neuropathic pain is always about damage to the nerve. That's it. This is how you differentiate them out. So don't look at the straight leg raise differentiating somatic from non-somatic pain. It doesn't do that. It's the quality of the pain that does it. Is that okay with everybody?
Yeah, that makes sense. Thank you.
Okay. Anybody else got anything on that? Because it's important. Okay, anything else from the videos or anything we've talked about or anything we haven't talked about that you're waiting to talk about? Okay, take you at the words. All right, now before I get into this a bit, let me say a word about being right and being wrong. I know this is stressing you, having to talk on here, and it's a new phenomenon for me. It's only been over the last 10 years or so that people have been really uncomfortable asking questions or answering questions coming to that. And I'm not going to comment on why that is because I really don't know, except whatever it is, it's our fault. Be wrong. If you were right all the time, you wouldn't have to do this course. You learn more from being wrong and failing than you do from being right and succeeding. There's neuroscience to back this up as well. The learning centers light up when you're wrong or you've failed at something. They just light up. They want more. So don't be frightened to ask questions. You're asking questions because you don't know the answer. That's it. It's as simple as that. Our job is to provide the answer. Okay? So you can't be wrong asking a question. You can be wrong answering the question, but that's okay too. But you can't be wrong asking the question. All right, so please ask as many questions as you want, get as many answers wrong as you want. It's our job to make you understand it. I'm the worst person to get on a course as a student, absolutely worst. My feeling is I've paid for this course. Your job is to make me understand what you're saying. My job is to try and understand it. If I don't understand it, let you know that I don't understand it so you can change the way you're explaining it to me. I'm a nightmare. I won't let it go. until I find everybody else in the class is exasperated with me. And then I'll just stop. But apart from that, I'll keep on at the instructor, because if I'm not getting it, there's other people who are not getting it as well. I can guarantee it. Nobody's stupid on here, all right? You're not average therapists neither. The average therapist doesn't do this type of thing. The average therapist is content with schoolwork and doing enough for continuing education purposes. You are definitely not average. You're well above average in that. So take every opportunity you can to question us. All right, we're happier with that way as well. The more interaction there is, the less we have to listen to ourselves and each other, is what it comes out to. All right. So be wrong as much as you like, preferably not in the exam zone. Okay, so let's have a look. I told you I was going to talk more about clinical reasoning. In fact, nearly all of these Zoom sessions are about clinical reasoning. So you can see that okay? Big red square with a blue one in it. Yeah?
Yes, we can see it.
Thank you. Okay, so I alluded to this last time about selection of technique and then the way you can do it. So we got pattern recognition, differential diagnosis, hypothetic abduction in one of a couple of different forms. So these are basically it. I can't think of any others that are particularly useful for us. So let's have a look and get an idea of how this might work with right low back pain, right posterior leg pain to the lateral foot. You've got to select a clinical reasoning technique. And we're going to do it formally now. You may not do it formally in the clinic, but you do it anyway, even if it's informal. So the question is, given that information there, this is what the patient's told you, and you've got to come up with an answer immediately, because that's the way your brain works. Now, do you want to do it through pattern recognition, differential diagnosis, where you have to prove each differential diagnosis, or hypothetic abduction, where you have to generate a hypothesis? So let's ask for a selection of you. Abby, you're first on the list. Which one of those three types would you choose to use in this particular patient?
I would most likely go with a pattern recognition, just because of the explanation of the posterior leg pain to the lateral side of the foot, thinking of like L5S1 potential, L4, L5S1.
Okay,
And
yeah, that's good. That's fine. That's absolutely fine. I would think most people would agree with that, wouldn't you? The problem is, pattern recognition says that you know that's what it is. That's your diagnosis. So are you still prepared to go with pattern recognition?
I mean, I should always use differential diagnosis, but the way that my brain works, that's how it is. But from your last video, I was told not to be too confident. So
No, you can be confident. I don't mind you being confident. It's overconfidence that's the problem. But at this moment, though, if you're using pattern recognition for this, you have to start treatment. Are you prepared to do that?
I think I could, yeah.
So you're absolutely sure that this is a disc herniation?
I mean, I can't be sure until I would have like an official MRI. So
No, you can't get that. It's your clinic. This patient's walked in. You can't now order an MRI, can you? It's your clinic. You've seen the patient. You've made the diagnosis. The next step is to treat it, isn't it? So you're sure enough that you're going to treat it. So let's look at the differentials here, which now the way it works is an expert will use pattern recognition if they're sure that that's the answer they've got. But what the pattern recognition guy does, and he doesn't know he's doing it, is he'll hold 2 or 3 different differential diagnoses in their head. And it's unconscious, or at least it's unconsidered, but they're constantly comparing what they're thinking to those differentials. So let me ask you this. If one of the differential diagnoses is lateral stenosis, would that fit this description?
Yes.
Okay, so now how sure are you that it's a disc herniation and treatment as a disc herniation is the correct thing to do?
Not so confident anymore,
Yeah.
Jim.
Yeah, that's exactly. There's a few things it could be. A disc is a good guess, though. I mean, it's a guess, though. What you've done there is you generated a hypothesis, a perfectly reasonable hypothesis of that. What you haven't done, though, is made a diagnosis with any degree of confidence when you apply differentials to it. Is that okay? Now, the expert using this would have done that automatically without thought. If he's doing this right. And he would have probably substitute. Well, he may not have substituted either, but it wouldn't have allowed him to start treating this as a disc herniation. Same way, it's not allowing you to do it. But what the clinical pattern guide does is automatically applies the differentials for this, which is not the same as what you did. What you did was recognize what it might be, which is absolutely fine. So this is your first generation of a hypothesis for hypothetic abduction. Does that make sense?
I think
simply-
I'm just a little. So, can you repeat what you just said with the hypothetical one?
Okay, so if you're doing hypothetic abduction, you have to generate a hypothesis because you're going to test that hypothesis to incoming information, subjective and objective. And you're going to make the best fit for what the patient's giving you to the hypothesis you have. So, for example, if your hypothesis was this a disc herniation and the pain is moderate, then it's almost certainly not a disc herniation. But I've got a feeling we may have to talk about a disc herniation. Can you have a moderate disc herniation? This is open to anybody now. Stephanie, what do you think? What have you been taught? Is it possible to have a moderate disc herniation?
I have heard that term be used based on how much the disc has protruded. Whether it's yeah, I know. Whether it's mild, moderate, or severe, I feel like are the terms that I have commonly heard used from MRIs, like the impressions from MRIs.
All right, that's a problem. It's the MRIs don't tell you anything about the clinical picture, nothing at all. Now, is everybody? You're going to get a lot on this later. I just want to do it now, quickly. There is a difference between a disc herniation and a disc protrusion. Have you been taught to differentiate the two? I'm going to take somebody as a spokesman here. So let's have a look. Kristen, do you know the difference between the two? Have you been taught the difference between the two?
I do not think I've been taught the difference between the two.
Okay. Would anybody say they have been taught the difference between the two?
I
I'll take a
think I
crack
have an
at it, Jim.
understanding.
All right.
Oh, go for it.
Okay. So a herniation. Sorry. A herniation.
I would take a crack at it, and you can
Okay.
correct me if need be.
Go.
I'd visualize it in kind of grades, and so to me, a protrusion is typically described as the mildest, where we start to get a posterior lateral bulge or impingement, or it's at least starting to come away from its particular shape, right? It's starting to come out of its normal shape, okay? A herniation has been described as we start to get some disruption of the annular fibers, and then we get into more of a higher grade injury, if you will. And then finally, extrusion would be a release of the nuclear material through the annular fibers, and then we're subject to all the chemical irritants and cascade that can happen with that.
Okay.
Am I close on that explanation?
Sorry. All right, that's a mishmash actually of radiology and pathology. Don't use the radiology websites for this because the radiology only talks about the size of the bulging of the disc. We're going to use different terminology, which is old terminology, but works for clinical reasoning purposes and for treatment purposes. A herniation of anything is an abnormal migration of one tissue through another. So this is your disc, okay? So a herniation is this occurring, all right? That's a herniation of nuclear material through the annulus. Now, that is going to cause bulging of the disc. This would be a prolapse, all right? And it can be larger or smaller. And the larger it is, the bigger the bulge is. Is that fair enough? An extrusion is this.
I was able to get much faster.
Hmm?
Yeah, let me,
I'm not sure if that's just external, extraneous sounds or somebody's asking. I still can't hear it. So is anybody asking a question? Give me a hands up if you are, would you? Although I can't see everybody on here.
Can you please repeat what you said about the disc protrusion?
Well, I haven't done the disc protrusion yet. This is a
What was the
prolapse.
second one?
That's a
What
prolapse.
was the? Oh, okay.
All right,
Got
so prolapse. This is an extrusion. And if this fragments, this becomes sequestration. These are fragments of the nuclear material. And you're right, the nuclear material is neurotoxic. Simple contact with the nerve will degenerate the nerve. So this is a really severe thing and will damage the nerve. So this is generally when you're going to see the neuropathic pains. These are things that are probably going to need surgery and are not likely to recover on their own. And the damage, actually, the nerve is semi-permanent. This, on the other hand, produces a bulge. Now, that may not damage the nerve. It may not be enough of a bulge to do compression. But what it's going to do almost certainly is affect the dura of the nerve root. So you'll get dural signs with this. You may get neurological, you may get a radiculopathy. It depends how big the prolapse is. But you're certainly going to get dural signs with it. Is that okay? They're your herniations. All right? And it's an abnormal migration of one material through another. Are there any questions about that? Okay. So a protrusion is this. So it's a bulge of the annular material. Now, why it bulges is speculative, but what it might be is I don't want to get too deep into this. Degeneration of the disc actually results in disc height increase and not disc height loss. You'll get this later on. Right now, take my word for it, okay? So what early degeneration is separation of the laminae in the disc. That's what it is. So the disc actually gets more fibrotic. You lose mucopolysaccharides, so you get these circumferential clefting, and you'll get separation of the laminae. Now, in some cases, that will be focal, and it will line up, and you'll get this sort of thing happening. So that they'll line up, and what can then happen is they will join together, and you'll get a radial tear through the disc. Don't want to go there just yet, but that is probably going to produce or may produce a weakness in the disc that allows the disc to bulge out. Does that make sense?
Can you repeat what lines up? I didn't quite catch that.
The annular cleftings. So All right, this is your annulus. All right, it's a series of concentric layers of collagen. Yeah, is that okay with everybody?
That makes sense.
It's what it is. These are concentric ligaments, basically. They're ligaments in contact with it. There's about 8 of them, 8 layers. Degeneration initially involves this sort of thing happening. You get separation between the layers there. It's called circumferential clefting. Is that okay?
Yep.
Okay. Now, sometimes, probably to do with the orientation of the facets, although this hasn't been proved, it's speculative, if the facets are too oblique, you're going to get rotary stresses set up in it, and that degeneration may then be focal. It may be directional. That will produce a weakness through the disc, and the disc will bulge. That's a protrusion. It's a non-herniated bulge of the disc. That tends to be quite small. It may produce dural signs, but it won't produce the severity of symptoms that a prolapse and an extrusion can do, or will do actually, when they're symptomatic. So this is, you're right about this. This is much milder than a prolapse, and a prolapse is much milder than an extrusion. So they're on that grade, but the pathology is what's important here. Is that all right?
So with a disc protrusion, is there no like leaking of like nuclear material like onto the nerve? Does that never happen? Okay.
No, not with a protrusion. It will happen with an extrusion, and it won't happen with a prolapse.
Okay.
They're separated from the nerve.
So protrusion is mostly going to
that.
be. So protrusion would mostly be due to like degeneration in the annular tissue.
Well, yeah, it's always about degeneration of the disc, yeah, because what can happen with this is that these will link up, okay, and this is your typical. This is the current most common model of a disc herniation. So these will link up, and it gives a channel for the nucleus to herniate through. Is that okay? That's probably how you learn about disc herniation, wasn't it?
Yes.
Yeah. The problem with that is they've done cadaveric studies where they've taken a healthy but degenerate disc and actually in a cadaver, sliced it with a scalpel and then tried to make that nucleus go through it. And it wouldn't do it. It wouldn't go through. They've run trucks over it, bit on it, slammed it against the wall, done all sorts of things, and that won't go through it. What has to happen is that this nucleus has to be changed. Now, it's already changing through degeneration. It's becoming less watery, there's less protein in it, and so on. But it won't go through it without that change. The one explanation is that if you tear the annulus, under these circumstances, the blood vessels will invade and they will vascularize the nucleus, and that will change the makeup of the nucleus and allow it to flow out. The other possibility is that the disc does actually herniate, but it herniates upwards. So there's your disc. And you have enough force on this that the disc will herniate upwards into the end plate, possibly into the vertebra. If it goes into the vertebra, you're seeing Schmell's nodes. But maybe just into the end plate, it's then vascularized, and now you have this occurring. Okay? Now, there's no channel for this to go out. And then this, and if you get these radial tears, then it has a channel. But what this can do is actually do this. You're going to get this on videos in a couple of weeks anyway. But what happens then if you're looking down on the disc this way and you've got these clefts forming there all through it, then the nucleus, because it's now been vascularized, will work its way between these clefts like that. It still won't herniate outside of the disc and it won't bulge your disc. But once this reaches the outer third of the annulus, it can hit the nociceptive part and the disc becomes painful. So you can have referred pain down one or both legs, but it's all coming from the disc. Now the straight leg
Tim,
raise,
is what you're describing right now, is that still considered a disc protrusion because there's no actual herniation?
There is
What would you
herniation.
consider those?
No, there
Okay.
is herniation. The nuclear material is herniating within the disc. So you've got herniation from the nucleus through the annulus. So it's still a herniation, just hasn't breached the annulus. It's like a prolapse, only unorganized. Is that okay?
Okay. Yeah, yeah.
And then all of the pain you get now is from the disc. So straight leg raises are negative, but anything you do to stress the disc is painful, or it can be painful. That's called an internal disruption, or a what's the other term for uncontained herniation. Sorry, I interrupted you.
No, that's okay. I'm trying to relate what we're discussing now back to the dural discussion we were having earlier.
Okay.
So is it fair to say that we would see more dural symptoms with a herniation versus a protrusion?
Yeah. Yeah. But not with this herniation, because there's no bulge.
Right, right.
Yeah. Yeah,
Okay,
you're right.
okay.
You were right in the first instance of talking about the grading of this. Protrusions are mild, prolapses are severe, extrusions are really bad. Okay, so you've gone from mild to really severe. You're right about that, but the pathology is wrong. And it's you might as well learn these terms now, but you're going to get a lot more on this. And the reason I'm doing this now is because we need to talk about differentials. There is one other thing that's worth noting, and it's just a mention there, is that they've actually done biopsies of externalized disc material, and in a lot of cases, even if not in the majority of cases, they found this to be immature collagen. So one thought is this acts like a keloid. So if you tear the annulus, this may be proliferation on the annulus that acts like a keloid. In which case, this isn't a herniation, it's got nowhere to go, which you can't reduce any of this stuff anyway, and you're stuck with this. Is that okay? Don't worry about that just yet, though. Is everybody good? So the reason I want to do this now is because we're going to look at differentials for this. Yeah. So you really don't have enough. You don't have enough information there to say this is a disc herniation. What about if this guy turned up, he's complaining of those types of things, and there's no deformity with him? Now, with a disc herniation, you're going to see a severe deformity. This is a catastrophe for the patient. Either a disc herniation is asymptomatic, which it can be, and it is actually. A lot of these stuff are showing up on MRIs and they're not producing any symptoms. So this can be asymptomatic. A lot of this pain is produced by inflammatory changes. But if the disc herniation is symptomatic, it's a catastrophe. They have a severe, almost always a severe rhodoscoliosis. So if this patient turns up with no deformity, the chance of it being a disc herniation is not very high. It makes then your pattern recognitions argue for lateral stenosis. But this can also be a biomechanical dysfunction. Just because it's going all the way down the leg into the foot, provided that's not neuropathic and it's somatic, that can be coming from any tissue that's derived from the same dermatome as that supplying the lateral foot. Is that okay?
Yeah, something I considered was gluteal referral as well with this.
Yeah, absolutely. So if we look at the differentials, So I don't think what I was going to say here, pattern recognition is probably not the best thing to pick given the information you've got. So you're either going to pick differential diagnosis or hypothetic abduction. Is that okay? So if we look at, all right, let's do this. Actually, I'll put this one up as well. At what point do you see the pattern? Okay, so wrong one, sorry. Here we go. So the first one is right low back pain. Can you pick up a pattern from that? There's too many things can do that. You haven't got a chance to get a pattern from that, have you? So right low back pain and right leg pain. Again, there's a lot of things that can be, and you haven't got enough information for a pattern. Moderate pain. So you're going to start eliminating things like a disc herniation, but you still don't know enough there, do you? This could be a biomechanical dysfunction. It could be lateral stenosis. There's pain on walking or standing for 10 minutes or 20 minutes, respectively. Now, is there a pattern? Anybody want to have a crack at what the pattern is? It's telling you?
Yeah, the pain on walking or standing 10 to 20 minutes. So that's a consistent.
With what?
Possible stenosis.
Sorry, you said consistent. Yeah, absolutely. Lateral stenosis. Yeah, now you've got enough there to recognize a pattern. No pain on sitting is reinforcing the pattern, and no deformity. So you need information to recognize a pattern. You can't do it usually on the first couple of symptoms, not with any clarity. And don't forget, you're making the diagnosis through pattern recognition, not generating a hypothesis. Pattern recognition is the diagnosis. Are we good with that?
Jim, can you expand on deformity? Are you referring to possible postural deviations that we would typically see with either a disc or even a lateral stenotic patient? For instance, a lateral shift, or with our stenotic patient, they present with a lot of lumbar flexion. Is that what you mean by deformity?
Yeah, but you can't say a lot. In fact, there may be so little that you can't see it. So essentially, no deformity means you can't observe. It doesn't mean to say it's not there. A kyphosis, a minor kyphosis, is not observable. A severe one might be, but a minor one isn't. But you can palpate it often. A disc herniation is the deformity there is severe. This is an uncontained herniation now. This is your prolapse or extrusion. So you're going to see a severe deformity. It always involves kyphosis. It always involves rotation and scoliosis. So it's a rotoscoliotic kyphotic deformity. Okay, but it's very obvious. It may not be obvious with stenosis, especially lateral stenosis. Yeah, is that okay?
Yes, sir.
Okay. So this is what you need for a pattern. You can't just jump on the thing because, again, there's consequences to that. You're going to treat with it. So differential diagnosis. Given what we got, we had right low back pain, right leg pain down to the lateral foot. So what have we got here? Spondylolisthesis. What do you think of that as a differential? It's a rubbish one. Why? Patrick, I see your name there. Just caught my eye.
Can you repeat the question? Why is
spondylolisthesis a rubbish differential diagnosis for presentation?
Because it can present in so many different ways.
Well, the spondylolisthesis actually doesn't present in too many different ways. How does it present? What's the obvious thing about spondylolisthesis that isn't present in this patient? you're not going to be happy with yourself if you don't give me the answer.
Bilateral symptoms.
It's bilateral. Yeah, you're right. It's a bilateral stenosis. It's a central stenosis, actually, is what spondylolisthesis is, a particular subset of it, but it's a central stenosis. So it's always bilateral. This is unilateral. So it's a rubbish differential. And it isn't really worth making that because it's so far away from what the patient's dealing with. It's a waste of space. Yeah. So let's ignore that. Disc herniation without radiculopathy or a disc herniation with radiculopathy. Now, if you did this right, what the physician would do, if these were his differential diagnoses, he would order an MRI before he makes the diagnosis, all right? He still only generates a hypothesis, and he waits for the diagnosis because of the MRI. You don't have that luxury. So your diagnosis comes at the end of the session you're examining them, or it doesn't come and you fail to make any sort of diagnosis. And you refer them out or you have another bash at them later on. But you fail to make the diagnosis because you're left with a hypothesis. Now, this is why negative differentials are so much easier. We got rid of spondylolisthesis really easily. We can get rid of these two easily if we get the right answers to questions or the right answers to tests. Now, the right questions are, first off, is there a deformity? Well, it went. Is there a deformity? Is there a deformity? No. How severe is this? Moderate. Okay, then it's almost certainly not a disc herniation. If the answers were, yes, it probably is a disc herniation, your next test is going to be a straight leg raise. If the straight leg raise is negative, you can pretty much rule out a disc herniation as a prolapse or an extrusion, but it could still be the contained disc herniation. Is there a radiculopathy? Look for the clinical signs of a radiculopathy. Is there segmental paresis, segmental sensory loss, segmental distributed hyporeflexia? Is there paresthesia? Yeah. If the answer to all those things is no, and it's non-neuropathic pain, then it's not a radiculopathy. Maybe a disc herniation with a radiculopathy, but it isn't one without a radiculopathy rather, but it isn't one with a radiculopathy. You good? But you can see the problem. If you went through every test you think is appropriate to prove a disc herniation with or without a radiculopathy, you're going to spend a long time saying, oh, that's not what it is. So this is a very cumbersome way for us to do this, but nonetheless, let's stick with it for a bit. So the next differential, lateral stenosis. Okay. How do we prove that? Or alternatively, if you prefer it, how do we disprove it? Now, you haven't had a lot of exposure to disproving hypotheses, but you've had exposure, a lot of exposure to proving the hypothesis, yeah? You go in there, normally you've got the diagnosis in mind, you then do the tests that are appropriate for that diagnosis. Is that pretty much it?
Jim, I would look at compression versus distraction. I would look at what happens when I have the patient extend.
Yeah, that's
or even
it. Yeah, I mean
combinations of side bending and extension. Some of our quadrant testing.
Yeah,
H&I type stuff.
Yeah, but compression and torsion, compression and traction don't work terribly well. You've got to be really careful of that. They don't work very well for almost anything. The problem is you've got the patient laying on their back, they've got no pain. So what are you going to do? Increase their pain? They've got no pain? Anyway, it doesn't work terribly well. But yeah, look at the range of motion. What you're expecting to see is this, isn't it? Basically, this is your movement diagram. You use these. Flexion, extension, right side flexion. It's like you're looking down on them. And right rotation, yeah? So what you're expecting to see is something like this. Maybe that, we'll ignore those, but you're expecting to see that. And if you're doing quadrants, you would see, you would see that. Yeah? Now, given everything else you've got, that is back pain on the right side, pain going down the leg, this range of motion picture, the only question now is there a radiculopathy, isn't it? Is there anything else this is likely to be?
Jim, I haven't seen one of these diagrams before. Would you mind explaining the lines that you drew after the quadrants?
Oh, they were crossing it out. Sorry, okay, this is limitation. Sorry. This is a real nice way of noting range of motion. So this is flexion, yeah, and extension. And this is right side flexion, right rotation. So lateral stenosis would look like this, and probably painful, but certainly limited. So this denotes the pain. If it's moderate pain, it's that. If it's more severe pain, it's that. If it's really severe pain, it's that.
So
If
in
it's-
this diagram that you're drawing, Jim, are you saying that they obtain 50% of extension range of motion? Is that
You
that
can,
cross
yeah.
line?
Not necessarily, but I mean, that's up to you, isn't it? I've got that much limitation, or I've got that limitation of flexion. So it depends on what the limitation is. Yeah, you can
Okay,
do
I was
that.
just clarifying with alignment.
Yeah, you can do that. Absolutely, you can. So you can mark the range of motion down as a percentage, and you can mark the pain levels down as the number of positives you put into it. It's a really nice way of noting. It's very quick. It's easy to understand, and it's done. I don't know why they don't use this more in schools. Is that okay? Everybody all right? And the quadrant is going to be, it's going to, if we look at the extension quadrant, it's going to look like, sorry. The extension quadrant for a stenotic problem will look like that. There's your 4 quadrants and that. With or without positives. Yeah? Is that okay?
Jim, repeat that. You said that new quadrant that you drew is for what type of diagnosis?
That'd be stenosis. That'd be what it's also what a segmental dysfunction looks like, and the segmental dysfunction also looks like this. Unfortunately, it looks like a lateral stenosis. It's going to look like that if this is subluxed into flexion. So it can't extend, so you're going to see this happening. The difference is, though, the onset of the thing. You're going to get basically, this is going to behave like a subluxation. It's likely to be episodic, the pain is going to be moderate, and so on and so on and so on. So the history is going to be a little different. But the other thing that's going to help you out here is the PA. If this is a degenerative stenosis, the PA on that segment is going to feel stiffer than the other segments. If this is a subluxation, it won't feel stiff. If it feels anything at all, it's going to feel jammed. So you've still got a little way of improving this, but it's not a lot. Are you okay with that? But forget that for the minute. Just concentrate on the stenotic problem, because there's more background you need to read this. So if we're getting that pattern, plus the PA, stenosis is looking pretty good. Yeah? So what else have we got here? No way. Biomechanical dysfunction, possible fracture, possible neoplasm. Now, we talked about biomechanical dysfunction, fracture. There should be a history to this, shouldn't there? If we've got a fracture that's not of the vertebral body, the chances are this isn't a pathological fracture. So we need trauma, and we need a sudden onset of severe pain. Even if this is a pathological fracture, there'll be some form of trauma. Could be very mild, but there'll be a trigger and a sudden onset of pain. if this is a pathological fracture. Stress fractures react differently, but if it's a pathological fracture or a healthy fracture, you're going to have a trigger or a cause if it's a healthy bone fracture, but a trigger that is some trauma, which you may not consider heavy enough to cause a fracture, but trauma nonetheless, and then a sudden onset of pain. So we haven't got that history. Neoplasm, we can't prove. Neoplasm, you can't prove this. The idea of them having that all the signs and symptoms of cancer occurs in the last stages of the cancer. They rarely occur in the first stages. So an early stage bone cancer could look like a biomechanical dysfunction. So you have to eliminate everything else, and then you're left with a possibility of neoplasm. So all of those diagnoses have to have been eliminated, and that's what you're left with, because you can't prove it clinically.
Jim, when you're talking about biomechanical dysfunction, is it, expand on that a little bit more for me, please.
I don't want to really get into this right now, but the biomechanical dysfunction is what we're teaching now. The easiest way to think about this is a dysfunction that you can treat with manual therapy. Is that okay?
Yeah, so the potential of a gluteal referral would fall under that category of biomechanical dysfunction.
Oh, yeah, and the pain, generally speaking, the typical biomechanical dysfunction won't have much in the way of referred pain. It won't have much in the way of standing pain. It will be an activity pain, and the pain will be moderate, sometimes moderate to severe, but the basic pain is always moderate. Because it's a moderate pain, the referral tends to not be very high. So the typical biomechanical dysfunction has non-extensive referral, but an atypical biomechanical dysfunction can refer a long way. And it can be severely painful, which is why it's not your first choice as a hypothesis. Your first choice as a hypothesis is probably a disc herniation. And then when you disprove that, you move to lateral stenosis. You disprove that, and what you end up with is a biomechanical dysfunction, but it's way down the line of differentials. Is that okay?
Yes, that makes sense.
Okay. So you end up using this process with lateral stenosis again. Properly speaking, you should be doing positive differential. That is, you should try to prove each one of those diagnoses, but it doesn't work for us. Like the doctor does it with imaging and lab tests. We don't have that. We've got to come up with a diagnosis before we finish with the patient of the day, and preferably initiate some form of treatment. So this doesn't work for us. So negative differential diagnosis is the way to go for us. Is that okay? Or we use hypothetic abduction. Now, I'm pretty sure you learned this as hypothetic deduction, didn't you? No, it's late, isn't it? Is that how you learned it, hypothetic deduction?
Yes,
I'd
I
say
would
so.
far more.
I'd say so.
Yeah, okay. So a deduction in logic, which is also critical reasoning, but a deduction is an inescapable conclusion if the premises are correct. So if I said all humans have 2 legs, all other mammals have 4 legs, that would not be a deduction. That would be wrong, because the premises are wrong. So what I could say, all humans have 2 legs, all mammals have 2 legs, therefore only humans have 2 legs. Anything with 2 legs is a human. Yeah, that's obviously wrong, because apes have 2 legs, all monkeys have 2 legs. If I said all humans are essentially hairless, this animal is hairless, therefore this animal is a human, that deduction would essentially be correct. All right, there's going to be exceptions that bald monkeys, for example, but that's essentially correct. And we're not hairless anyway, but essentially we are. So we can't use deduction. The only time we can use deduction because our premises are not correct. Like we're getting information from the patient. So first off, you're taking the patient's history. You have no idea if he's telling you the facts or if he's interpreting the facts a different way. So you can't be sure of the premises. And how good are your tests anyway? Have you got any tests that are 100% sensitive and 100% specific? And the answer is no. When you do get that, these are called pathognomic signs, and they only show up with one disease, copper irises, copper rims around the iris, shows up with Wolff-Wilson syndrome. So if you see that, you can say, this person has copper irises, they have Wolff-Wilson syndrome. Almost never happens, and I don't think it ever happens in manual therapy. So we can't say it's deduction. This is abduction, and abduction is making the information you have the best fit for the hypothesis you have. So this is all about probabilities. There's absolutely nothing certain about this whatsoever. You're increasing your knowledge, applying it to the hypothesis, and then essentially applying Bayes' theorem to this. That is, with every piece of information, you change your opinion on the probability that the hypothesis is the diagnosis. It either goes up or goes down. But at the end of the day, it's all about probability. All right, you've got no other choice in this. Is that all right? So we're not going to get any further today with this. This is where we'll start next time, all right? You okay with that?
Yeah. Hey, Jim, I got one question.
sounds good.
Yeah.
It really kind of goes back to bias correction in this process and probably in the differential diagnosis as you go through it. Could you explain kind of how in the past you've explained this as using some of these processes as your bias correction to kind of either further confirm or refute your, current hypothesis?
Yeah, we've got to get into bias. You're going to be biased. We all are. You're going to have availability bias where you pick the best, you pick the diagnosis that you're familiar with or a course you've just done. You've all done this, and you've been on a course, and the first 6 people who walk in that day all have the same bloody diagnosis that you learn on the course. That's availability bias. Then confirmation bias is where you make all of the evidence fit that availability bias. Anchoring is where you get so much information, it's overwhelming, and you anchor to the first piece of information that makes any sense at all. That's bias. We're going to have to talk about correcting it, which you can do, and it's mostly done through differentials. So if you're going to do this right, you're going to do differential diagnosis anyway, either in the generation of the hypothesis or in pattern recognition or in hypothetic abduction. You're going to use it one way or another. What I'm saying to you is don't use it to make the diagnosis, not the way it's supposed to be used because it's cumbersome. Is that okay, guys? Well, I'll cover that a lot more next time as well.
Okay, good.
All right. Can I ask you something before you go? Dave, did you send them the synopsis of the last Zoom session?
Ooh, I don't think I included that as an attachment.
Okay, can you send it off to them?
Yeah, I'll add that in.
Okay.
I'll try and do that and get this recording up tonight.
Okay, and then if you let me know if it's useful or not, I'll do another one for today. There's a short synopsis